Good morning, everyone here on the West Coast and on the East Coast. I think it's about lunchtime. So thank you for dialing in. Hello, everyone, and welcome to our WTF series. This segment is on Can We Finish? Yes, we can. That's the title of it. And my name is Dr. John Pham. I'm one of the founders here of InBrace, and I'm joined here by two very special people. We got Dr. Tera Poole and Dr. Robert Lee. So wave hi.
Hey.
Great. Dr. Lee has been with us on this InBrace journey since the very beginning. He's one of the most brilliant people I know, a biomedical engineer by training, one of the co-inventors of InBrace, a clinical orthodontist, and the father of two very beautiful children. He's joined by the amazing Dr. Tera Poole, our director of clinical. Dr. Poole was previously a director at a fast-growing aligner-only DSO, where she managed multiple practices across the nation. She quickly realized that there's a better way of treating teeth with the InBrace SmartWire, and I'm happy to have her here today to share some of her clinical pearls. This is a webinar format, so by all means, if you have any questions, use your chat function, raise your virtual hand, whatever it is to get our attention. And, we want to keep this collaborative and conversational if possible. And also make sure that we keep the format going. So with that being said, I'm going to hand the stage over to Dr. Tera Poole. Can we finish? Yes, we
Yes,
can.
we can. Thank you, John. And thank you all for joining those early morning who might be on the West Coast and for those on the East Coast at your lunchtime. To get started, I just always like to start off with a reminder of the resources that exist for you already. So we do have our lovely in-group, and if you haven't joined, don't miss out on the conversation, so go ahead and be a part. We also have some online resources for you within our knowledge base and our learning dot, which is learning.inbrace.com. Here you can find our various modules, podcasts, and also our previous recordings of the WTF series. And straight hot off the press is our new mini residency that is available specific for Gen 2. So kudos to Dr. Lee, who's also on this call, but kudos to him for this Gen 2 mini residency for his support in building it out. And now to get started about our webinar on finishing. So we like to say that 80% of orthodontic principles apply no matter what modality you are using. The remainder of the 20% comes down to the respective nuances specific to that modality. With brackets and wires, this could be arch wire selection, your use of auxiliaries, and or flipping, switching the brackets, things that we've learned, the pearls along the way. And for aligners, the nuances can be staging the specific movements or thinking about your attachment designs. And just as we think about that 20% of nuances with brackets and wires or aligners, InBrace is no different. And with any digital workflow or orthodontic treatment, it all starts with proper diagnosis and treatment planning. Only once the proper diagnosis and treatment plan has been complete, and then you go through your appropriate stage goals, are you ready to finish out the case? This is what we learn in residency and what we do on our day-to-day. You can think about it by your different stages of treatment. You have your level and aligning, which is essentially our stage 1, then your working or your inner arch mechanics, which is our stage 2, followed by your detailing and finishing. As a quick overview before we get into the detailing and finishing, when it comes down to diagnosis and treatment planning, you can refer to our module 3 of the mini residency, the Gen 2 mini residency that's now out. And also don't forget the resources that we have available to you to ensure that you're setting up your smile designs predictably and you're checking off that first step of diagnosis and treatment planning correctly. This is our quick reference guide. If you haven't had it given to you by your TIS in office, feel free to ask because you do have these available to you. And it's essentially our cheat sheet or one-pager quick guide that gives you a checklist for everything that you need to look for in your smile design and a systematic approach, along with going through each dimension one by one. And so I know a lot of this is what you already know, but let's face it, many of us are going through our smile designs and our setups in between patients, so our minds are in a million places at once. And this is a perfect resource also that you may want to train on to your office manager or your lead assistant so they can help you set up your smile designs as well. When we talk about the systematic approach to setting up your smile design, again, the 20% are the nuances specific to the modality. The other 80% are the biomechanics that you already know that go into setting up that design or designing that patient-specific ideal setup. I'll be discussing setting up the smile design for success to finish. Dr. Lee will be talking about the clinical approach to finishing. And for overcorrection specifically, we will have a webinar focused on that in November, but we have introduced early access to our InBrace Intelligent Force Systems, which takes some of the lift of the overcorrections off your plate, starting with those 20% of nuances that are different for InBrace. And the specifics of those are the space opening and closing due to inner bracket distance, root tip and root torque overcorrection, vertical overcorrection due to torque specifically, rotations, and additional virtual power chain. And so these are the InBrace specific overcorrections again. So that's why we call it InBrace Intelligent Force Systems that are added post-approval to your smile design. So it's something that you don't have to think about, and it will set up your smile design to be more predictable when it comes down to the finishing and detailing phases. I will be touching on some of these movements in this webinar, since it does relate it to setting up your smile design, again, that first stage and getting to the finishing part. And a webinar on IFS will be coming again in November. Just to call out that you are responsible, even if you do have early access to IFS and you have opted in, you will be responsible for the standard or the 80% of orthodontic overcorrections that you apply in any case that you're doing. So vertical overcorrections, for example, in traditional, you might add in a reverse curved speed wire. And aligner, your setups, you're gonna add that reverse curved speed when you might over intrude the lower anterior teeth. Your AP correction, so if you're utilizing elastics, and also your transverse. An easy way to think about this, if you are using your quick reference guide to set up your smile designs for success, then you can think about this, that the right side, or those last two portions, are IFS specific, so the InBrace Intelligent Force System, and the left side of the page, the vertical, the AP, and the transverse are things that you want to add in to overcorrect yourself. And just as a reminder, if we look at kind of those stage goals, stage 1, again, you can think about that as your level and aligning. Your stage 2, your working or your inner arch mechanics, and then you can get to your finishing and detailing. The details of these 2 stages and the approach to take are within module 2 of our mini residency. But as a quick refresher, for stage 1, you can think of this again as your leveling and aligning, your light tie wires that you're using, and equivalent to our Smart Wire 0 or your specialty Smart Wire and Smart Wire 1. Your stage 2 is your working or your inner arch mechanic, and that's your Smart Wire 2 and or your Smart Wire 3 if you need it upon request. And if you haven't finished in stage 2, which in many cases you can finish in stage 2, but if not, and you need to do a little detailing and finishing, then you can do that within your digital enhancement. Said this, but your stage 1 purpose is to do your level and aligning, and to specifically bond all the brackets in their planned bracket position, to perform any IPR that's needed, and to allow that smart wire to fully express. We do recommend that smart wires are left in at minimum about 4 months to allow full expression of that smart wire. The most important step here and the most important goal to make sure you achieve in order to finish correctly is bonding all their brackets in their planned bracket position or their most ideal position. And I have some slides later that you can see the side effects of not having brackets in the most ideal position. For stage 2, as mentioned, this is your working phase or your inner arch mechanics. And so the goal of these stages is to allow full expression of that Smart Wire 2 and or 3 if you decide that you need to use Smart Wire 3. And again, we do recommend staying in a Smart Wire for up to 4 months. You also want to resolve or nearly resolve all of your inter-arch discrepancies. This will allow for arch coordination at the end when you do want to finish, and remove or reduce your bite turbos if you have placed those. And the most important stage here or step to make sure you're finishing predictably is to make sure the inner arch discrepancies are resolved as close as possible, as a reminder to get your arch coordination that you need to finish out the case. And so when it comes down to detailing, doing that those final touches to make sure your case can finish out, one component is the smile design, and then the next stage is the clinical approach to take. Again, if you look at the smile design, you may not need to enter a digital enhancement if you set up that initial smile design appropriately with all the detailing and finishing touches within that smile design. But if you do, then you can submit a digital enhancement. And the main piece here to call out if you are finishing or detailing with a digital enhancement is to first make sure that you're submitting the proper records that we can use. And the first piece of submitting a good record or the proper records for a digital enhancement is providing a good tooth print. We need an unobstructed view of all the brackets with a digital enhancement scan. So remove the soft flow that you might have on, remove flexible bite turbos or anything else that may be blocking those brackets, because what we're doing is we're superimposing the brackets on top of each other when we are fabricating your smart wire. So if there is obstructed view of our bracket, then it can make it difficult to fabricate the smart wire predictably, and or you may get a repo within your case. So the first piece is making sure you're taking a good tooth print. I usually tell the assistants that in studio, if I'm taking a tooth print for just progress check versus if I'm taking a tooth print to submit for digital enhancement. So they make sure they dry the teeth, clear all the saliva, and make sure all the brackets are visible. This is generally what we do receive when we do get a digital enhancement. So we get the STL file, and for photos, a lot of providers just submit the photos of the STL. You can do this, but we do recommend sending in your frontal smiling photo with your digital enhancement. Reason being is as we treatment plan and set up your smile design, if we don't have the frontal smiling photo, then we can't ensure that the occlusal plane of that setup is true to the patient. This is a prime example here. If I was to draw a line, you can see without the frontal smiling photo, that occlusal plane could have been at a cant, which can affect the detailing and the finishing of those upper anterior teeth. And so if you provide us with a frontal smiling photo, we can reorient that occlusal plane of the STL file in the bite so that we're finishing and detailing true to that patient and give you the most predictable finish. We also recommend a progress panel, just as you do with your traditional brackets and wires when you're in mid-treatment and you're trying to see if you need to repo any brackets for any reason or add any root tip or torque. And then we recommend the exact same. So if you provide us with a progress panel, we can assess the roots and the angulation and decide if we need to add in any tip. A common question that we do get is if bite turbos need to be removed or reduced prior to submitting your digital enhancement and or finishing out the case. If you're doing a mid-course correction, so there's a lot of things that still need to be done and you're not doing any detailing or finishing, or you're trying to finish in one fell swoop, then you can leave the bite turbos on. However, if you are ready for finishing and detailing and you're submitted on a digital enhancement, then we will not be able to see the true occlusion or the bite of the patient. And so we do recommend that you remove the bite turbos to submit your scan so that we can see the bite. Otherwise, we will be guessing and trying to orient how that bite fits together. Additionally, with flexible bite turbos, as just mentioned earlier, seeing the brackets is ideal. And so we do recommend removing flexible bite turbos prior to taking your DE scan and placing those flexible bite turbos back on. It's very, very easy and quick to remove these flexible bite turbos. You can take a scalar explorer, flick the flexible bite material off, and then replace it when you're done, your assistant. And the reason we recommend, again, taking them off is so we can see the brackets, but the reason we recommend putting them back on prior to having your patient leave is because occluding on the brackets can cause enamel wear. So this comes down to really any appointment that you bring an InBrace patient in for. You should be checking if there are any interferences or potential for biting against a certain bracket. And if so, adding a little flexible bite turbo material to that will ensure that you don't cause some enamel wear to the lower anterior teeth of patients. We've also gotten a question because Ferment was discontinued of what bite turbo material that we use, and we do use Telio now. You can get it from Henry Schein. It's made by Ivoclar. Also, when it comes to finishing and submitting for digital enhancements, we do recommend to check with floss. I have the assistants do this chair side to see if there's any light contacts or no contacts at all, and specifically list out those areas and report those spaces in your DE submission form so that we can add additional virtual power train or kind of overclose those very, very small spaces, because the scanner or the tooth print may not pick up those small spaces accurately, especially if there's some saliva in the area. Lastly, when it comes to your smile design and setting up your case to finish predictably, we want to look at kind of each individual tooth and go through our individual tooth assessment that we have within the quick reference guide. And if you have opted into IFS, then a lot of this is covered within the InBrace Intelligence Force Systems overcorrection that's added in behind the scenes. But I will go through a little bit of it so you can think about this as you're finishing out your cases and setting up your smile design. So the first part, or the first thing that you want to look at when you're going through tooth by tooth and assessing for finishing and detailing is remove any unwanted or unnecessary tooth movement that may be added into the smile design. When we talk about digital enhancements or finishing out cases, then we like to say take the less is more approach. So only move the teeth that require detailing. You can think about this as if you're finishing or doing final detailing in your traditional brackets and wires, you wouldn't put a bin between every tooth. And in the same thought process, you don't have to move every tooth in your digital enhancement. Do not do so. Only add the movements that are necessary. In terms of necessary versus unnecessary tooth movements, one kind of specific movement that we like to call out is single tooth torque. Reason being that single tooth torque can create a step up or step down side effect. So we do recommend when you're trying to finish out a case or detailing a case to remove planned single tooth torque if you can, because of this vertical side effect that it can cause. The reason being, you can see in this case, there was labial root torque planned and that caused an intrusion side effect. Because the teeth are on the brackets are on the lingual side of the teeth, when you add in that palatal root torque, you can see how the tooth moves, and this results in an extrusive side effect of the bracket and essentially a step down bend. The opposite happens if you add in labial root torque. You can see that the different colors of the brackets, how that vertical change in the bracket results in an intrusive side effect. So depending on what root torque you add on, you can see that there's a vertical bracket change due to the brackets being on the lingual side of the teeth that essentially is equivalent to putting a step up or a step down bend in your wire. If you're looking at it from the lingual, here's an example of what it would look like. And in this case that I just showed of when that labial root torque was added and why we got that intrusive side effect, because it was essentially equivalent to a step up bend in that wire if you're looking at how that wire would have been activated when ligated in. And so we do recommend, of course, to accept the torque if you can with that tooth and instead add a step in or step out bend. But if you do need and or want that torque, then you need to overcorrect for that vertical side effect by, in this case, since you're going to get the side effect of intrusion, you need to add in some extrusion to overcorrect for that. And for the step in or step out bend, this is what we recommend, or this is a depiction of it. So if you can see, instead of adding labial root or lingual crown torque in this case, which would cause that vertical side effect, because again, due to that picture that I just showed, if you do the torquing movement, you're going to get a vertical change in that bracket positioning on the lingual, versus if you do a step bend in this case, you wouldn't get the vertical change in the bracket position on the smile design. So you won't get activation of that smart wire, but due to the nature, physics, we all know biomechanics of how teeth move, that in reality, you're going to apply the force to the crown level of the tooth. So instead of getting a true step in, what you're going to get is just retroclination or that lingual crown torque that you were hoping for anyway, clinically. And so this is a way to mitigate or not have to worry about the overcorrection for the vertical side effect of adding in torque. If you do add in torque, then again, adding in the overcorrection or the extrusion to overcome the side effect that you're going to see would be what we would do specifically for IFS. If you have opted in, we will look at this for you. If you have not opted in to early access for IFS, this is something that you would need to add into your smile designs. However, with anything, adding an overcorrection and trying to counteract the side effect is less predictable than just avoiding it altogether. So we do recommend accepting that torque and doing a step in or step out in instead. The next piece that we say to look at when you're detailing and finishing your cases is look at any adjustments that you want to make to the leveling and aligning. We know this is specific to providers' eyes. Multiple providers on this call can look at these different setups and maybe want to do a few things differently or add in. So the one piece here, little pearl or nugget, is be as specific as possible to the smile design technician. So when you're getting your smile design back for finishing and detailing, they can see exactly what you're referring to and you're getting the best smile design that you can. The next piece that we say is to add an overcorrection for any individual tooth movement that requires increased force level, but we know this comes down to root movement most of the time. And so, as I mentioned, a progress panel is very, very helpful for us so we can see if you need any corrections to root angulations. In this case, you can see that that lower left 4 needs a little root tip. And so we would add in extra overcorrection to ensure that root tip plays out because we need a little bit of increased force in that level. If you are opted in to IFS, this is included in what we consider an add-in post-approval. Here's a case example. You can see that this case, all the stage 1 and stage 2 goals have been met. So all the brackets were bonded on the right piece, the most important piece for finishing out a case, and the inner arch discrepancies have been taken care of in stage 2, along with full time in arch wire expression. This is about 8 months. So each smart wire was left in for about 4 months time. And you can see that the upper right one has mesial root tip. Again, the progress records that we recommend, especially for DE, if you're trying to finish out a case, is that frontal smiling photo and an x-ray to make sure, and the panel helps us look at that root angulation. In the smile design setup, we added about 3 degrees of distal root tip to that upper right one to mitigate that mesial root tip that we were seeing. And we do teach that it's more about the direction, not necessarily the amount that you're adding in, but we do have guidelines in our quick reference guide if you want just something to refer to. In this case, we thought about 3 degrees would get us there. And you can see this is when we engage the Smart Wire 2 for the DE, and we let the patient go for about a month and a half before seeing them again. And you can see that the distal root tip had expressed. Again, direction is more important than the actual amount. Could have potentially gotten away with a little bit more, but the 3 degrees did what we needed it to do, and the patient and family were extremely happy. So you can see this is the difference between the initial and where we ended when we were finishing out. The next piece to look at when you're finishing and detailing your smile designs for success is looking at that upper central incisor rotation tip side effect. Heard us talk about this quite a bit. We posted in the N group about it as well, so won't fully go into the details of all the biomechanics behind it, but just a quick reminder, this is the case, upper central incisor, that upper right one needs some rotation of mesial out. When you rotate that tooth out, if you were to essentially cut the upper right one in half, and due to what we already know about biomechanics, that if you are proclining a tooth, you get relative intrusion. If you're retroclining, you're going to get relative intrusion. And so essentially on the central incisors, breaking that tooth in half, what it's going to create is that part that's coming out is going to get relative intrusion, and that half that's coming in is going to get relative extrusion. And what that means is when you see it clinically looking on, is that tooth is essentially going to tip. And so we know this happens. And with mesial out, distal in rotation, you're going to get distal root tip. A lot of providers remember that this, by whatever is going in, is going to be the way that the tooth tips. So distal in, distal root tip, mesial in, mesial root tip. And to mitigate this, since we know what's going to happen, is that we would add in overcorrection to the smile design to counteract that root tip that will happen. So for distal in rotation, distal root tip, your smile design will show mesial root tip and that upper right one being angulated the opposite way, and then vice versa for the distal, the mesial in rotation. But since we know this is going to happen, there may be cases when you're finishing out that this central incisor rotation tip side effect can be used to your advantage. So this is a case we do need mesial root tip, and so in this instance, it is favorable. So we wouldn't counteract the side effect that's going to happen. However, there are instances with the upper central incisor rotation tip side effect will be unfavorable. And this is a prime example. You can see those upper central incisors when you're looking straight on, good level to their incisal edges. And on the smile design setup here, if I click, you can see that there was rotation added into that smile design setup. And so that rotation of those upper ones is going to cause this side effect to happen and should be removed if it's unnecessary. In this case, the upper ones are in pretty good alignment and the incisal edges are pretty even. So if you can just accept the position of the upper one so you don't have to counteract the side effect, then that will be more predictable. But if you are adding in that rotation, then we will add in that overcorrection. Again, if you're opted into IFS, you're going to hear me say that a lot. But if you're opted into early access for IFS, then we will take this into account for you, and it's not something you have to think about. The other piece that we want you to think about when you're finishing and detailing out your case is adding an additional power chain if needed and where it's needed. So if you recall, I mentioned to ask your assistants to check with floss interproximally before submitting your DE scan or finishing out a case so that we can denote, and it can be relayed when there's small spaces that may exist that the scanner will not pick up. So we will add in additional virtual power chain or essentially overclose those small spaces that we do see. And this is added in for providers who have opted into IFS, again, early access to IFS. And there's one more reason that we add in virtual power chain is essentially when the inner bracket distance is increasing, then we will add in or overclose that space that may open. The reason here, again, is that our brackets are on the lingual side of the teeth. And so when teeth are rotated, essentially their brackets are becoming further apart. And our smart wire is fabricated on your smile design or that end result, which means that a bigger loop will be fabricated if we don't add in that additional virtual power chain or overclose that space, which essentially is going to act like an open coil spring. So you can see here on this image that where you started, that yellow line or that interproximal loop between that upper ones is smaller than that ending point or that red line when those teeth are rotated distal out and aligned. And therefore what we do is we overclose or add an additional virtual power chain. So essentially you're derotating those teeth, but you're ending in that same interproximal distance or inner bracket distance between those teeth when you started. Here's a prime example of some posterior teeth. And what I mean by those stages, you can see that when we started off in the initial submission, the inner bracket distance was about 5 millimeters. Those teeth were rotated just a little bit, but to get the detailing that the provider wanted. But you can see that that inner bracket distance increased to 6.2. So when that loop or that smart wire will be fabricated, since that distance is wider, essentially you're going to get a bigger IP loop design there, and it's going to cause an open coil spring effect and cause a little space to open. But with additional virtual power chain added in, you can see that we've overclosed that space so that the inner bracket distance matches the initial inner bracket distance, but those teeth are derotated, and that prevents a space from opening. Lastly, for setting up your smile design success is to look at your bracket positioning. You can do this when you are submitting for a digital enhancement because you do have the brackets on the scan. So if you're finishing out your case within the initial stage 2, then you won't be able to see your bracket positioning as easily. But if you are submitting a DE, then the one big call out here is to check your bracket positioning. If there are brackets that are significantly off, then that can cause issues with level and aligning and finishing out those little bit of movements that we may need to get to. And so you can ask for brackets to be virtually repositioned. Here's a prime example of a case that had a blocked out tooth to start with. And so that bracket was not a part of the initial IDB. However, it was direct bonded later. And you can see that the bracket was placed more distally than planned. And as that tooth derotated, the bracket was not repositioned. And so that bracket remained distal. With this bracket positioning, even if fabricating a smart wire based off this bracket positioning, it's going to be hard to get that last little bit of mesial in that you need just due to the bracket positioning. This is the same with your traditional, if you're doing brackets and wires on the labial, you're going to reposition your bracket to more ideal in order to get that last little bit of movement that you need. This is a case where the bracket was pretty significantly off. So in this case, we would recommend to ask for a virtual reposition of that bracket in a single tooth IDB tray to get that last little bit of movement that you need. Versus this case, the upper left 3 bracket is a little bit off from ideal or the center, not as much as the previous one. But you can see it's really just that one bracket and it just needs maybe a few degrees of mesial in on that upper left 3, whereas the other case needed quite a significant amount. So in this case, due to the minor amount needed, you can add in just a little bit of overcorrection for that rotation to compensate for the bracket position being off. You can see here in this smile design, there was a little bit of overcorrection added to that rotation to get that final detailing that you may need. And with that, I'm going to hand it over to Dr. Lee to talk about the clinical approach to detailing and finishing.
Great. Thanks, Dr. Tera. Okay, so I'm going to go over now the clinical approach with finishing. So Dr. Tera has kind of gone over the prerequisites for predictable finishing. We did a proper diagnosis and treatment planning. We completed the stage 1 and stage 2 goals. We submitted proper DE records. We proactively adjusted our DE small design to support your final detailing. So now what do you do actually when you start with seeing your patients? So in the beginning, you would just perform any of your clinical adjustments. So the first thing you would do is you'd look at your DE instructions that are provided with every digital enhancement. It may ask you to reposition a bracket. It may ask you that you may have asked to bond some new brackets on. You might have asked to do some IPR. You program that into your small design. So the very first thing is you just essentially just follow the DE instructions. Next thing you would do is you would insert the wire. Most of the time you're going to insert the DE small wire 2, and you want to let that fully express. So the wires that you get in your digital enhancement kit is you get a DE small wire 1 and a DE small wire 2. Most of your cases for DEs should start and finish with DE small wire 2. You don't need the DE small wire 1 in most of your cases. The reason why we give a DE small wire 1 is in the event that you needed to submit for an earlier DE, like a mid-course digital enhancement. Say you still had brackets that you needed to reposition, you still had some level and aligning you need to do. You needed more flexibility. You can't engage a DE small wire 2 yet. That's why we provide that DE small wire 1 in the event that happens or you need it. DE small wire 3 is not generally provided in the DE kit because most of the time the major mechanics, all of your major interarch corrections should have been completed already. It would have been done in your initial round of smart wires. So the DE small wire 3 is available by item request. You never would start with the DE small wire 3, even if you were planning on using a smart wire 3 in your digital enhancement. You would still always start with either DE small wire 1 or 2, and then work up to the DE small wire 3. So it's always you would always be able to item request for it with enough time when you need it. So when you are doing your final detailing, you would simply just engage your DE small wire 2. When you have just minor movements left, if you're doing that less is more philosophy, you just had a little bit of rotations or in and out movements, there were maybe some small space closures left that you're trying to close. That should express fairly quickly within one appointment interval, usually 6 to 8 weeks. If you're trying to do some root movements for finishing, like some tip or torque, sometimes it takes a little bit longer. So if it hasn't expressed after 6 to 8 weeks, your first appointment interval, you may want to let that go a little bit longer to see if it expresses in a 6 or 8 weeks. Usually it'll express after about 2 appointment intervals. If you do find that you need to do a second digital enhancement, totally acceptable. I mean, it's analogous to having to increase or decrease, or even maybe you miss some detail bands when detailing a traditional arch wire. Again, remember that when you're doing your adjustments in your DE small design, it's very similar to doing detail bends with traditional arch wire. So, again, you sometimes have to increase or decrease the amount that you did with your detail bends. The same thing. A lot of times we have found, though, that you can avoid doing another digital enhancement, spending that time, and you can finish a lot faster for the patient if you were to do some active retainer or reshaping the anatomy, which we'll be going over shortly. Sometimes what may prevent the DE smart wire 2 from expressing properly is in narrow anatomy situations, particularly with lower anterior teeth that are very narrow. If you notice that the legs of the IP loop are actually colliding with each other or overlapping, sometimes that actually prevents it from expressing how it's supposed to. So you can see in this middle image right here that the IP loops are actually colliding against itself. And in the picture on the right, the space is closed. So this is the exact same wire designed off of the small design that you approved. The only difference that we did here was there was an item request that changed the IP loop from coming off of the shoulder to the legs. So when you do that, it makes it so that it doesn't collide on itself. In your treatment instructions, you'll actually see that we have different designs. And so this is design 3, where it comes off of the leg instead of the shoulder. So again, if you ever do notice that this is happening, you can simply just item request. You don't have to submit a digital enhancement. You can just simply item request, which comes within a week or two rather than a digital enhancement, which you have to do another small design. So just item request, and they will send you this new wire with design 3. So you just have to simply say, like, IP loop is colliding on itself. Please please include a design 3 for narrow anatomy. Now that you've done, like, you followed the instructions, you put the wire in. If you had any remaining interarch discrepancies or you needed to settle the bite, you can run some elastics. So I always like to remind everyone that when you're running elastics with InBrace, you don't have like a rigid, straight stainless steel arch wire. You have a smart wire that's made of NiTi that has loops in between it. You don't have that same rigidity. So you don't want to overpower the wire. I've seen a lot of providers overpower the wire by going straight to like heavy elastics, what they're used to using with traditional braces. And that causes more side effects than needed. So with AP correction, class 2, class 3 elastics, you should use medium elastics. Particularly, you're going to mainly be in SmartWire 2 when you're doing your detailing. With vertical correction, we actually prefer, again, lightening up even more. If you overpower, use too strong elastics, you're going to extrude that individual tooth because, again, you don't have the rigidity of a straight stainless steel arch wire. So you want to keep it light, particularly when you're trying to close like an open bite. There are different patterns that we can use. A lot of times I like to try to take advantage of the IP loops because patients don't typically want to have anything on the front of their teeth, particularly on the upper anteriors. So the middle picture is what I personally use the most when I'm closing anterior open bites. I find it works really well, and that patients, young, old, can do it as long as they're taught how to do it. So 3/16" light, 2.5 ounce elastics. It goes on the IP loop of the upper ones down to the lower buttons on the lower twos. I tell them you have to take one of those elastic attachers, the elastic hook, put it right up against the palate, use your other offhand, the thumb of your offhand to push against the palate. So it's actually, you can pull that elastic attacher, you can pull it taut, and you can slide it underneath the IP loop. As long as they have taught the patient how to do this, then they can almost always do it. Once in a while, the incisive papilla is inflamed. If the incisive papilla is inflamed, you can't get it on the upper ones because the IP loop is just too close to the gingiva because of that inflammation. Usually the upper 1-2 IP loop is far enough away that almost always can be used. The only thing is it's a much smaller IP loop than the upper ones. So you then have to use a smaller elastic. So you would use a 1/8 inch light elastic. They're very small. So usually I have to pre-stretch them so that they they're a little bit easier to handle for the patient. But usually, again, patients have a little bit more trouble with the one on the left, the 1/8 inch light. But I found that every patient, again, essentially can do it. Now, if you have a patient that just wants life a little bit easier, they don't mind to have buttons on the front of the teeth, you can just run a box elastic. You can put buttons on the upper twos. We generally recommend when you're trying to close an anterior open bite or settle your anterior open bite to try to run it more anteriorly, so more off the incisors than just running up, like, say, triangle elastics, which you might traditionally use with traditional braces. We found that when you run it from the incisors, it's a little bit more predictable. And you also have to put, usually it's a little bit less buttons you have to place on. Other elastic patterns, you can do any type of settling elastic pattern that you'd like. You can run midline elastics. When we run midline elastics, normally we'll run a 5/16" 2.5 ounce light elastic. You can run any type of cross elastic off the IP loop. So this is just an example of running a class 3 cross elastic off the lower left 3/4 IP loop. You can run sling elastics, you can run box elastics, whatever elastics you want to settle with. This is when you do your settling. So again, in the general clinical approach with detailing is fairly straightforward. Most of the work essentially goes in the smile design that Dr. Tera went over. You simply, again, just follow your DE instructions. You let the wires express, run whatever buttons and elastics you need to settle the bite. When I was looking at different like finishing pearls, I was looking at like ortho pearls over the last couple of years, and I remember there was a big thread on finishing, and one of the biggest things, the most popular pearl that everyone kept saying was just take a burr when doing your finishing. So just reshape the teeth anatomically. So final thing is, I usually tell most of my patients, minor chips, minor differences in your incisal edges, I'm just going to polish it off for you. That usually, if the patient has that in mind or know that's going to happen, then that makes things a lot faster and easier in terms of finishing. You just have to get fairly close. Same thing with just doing, if they have chips already and they want me just to restore that, I might put a quick temporary filling on and let them know that their dentist can do a final restoration there. One thing that might be a little bit different that I have noticed with my InBrace patients is that sometimes I also have to do some enameloplasty from on the facial surface. So for minor rotations or in and out differences, a lot of times it's just due to the anatomy of the teeth. But one thing that's a little bit different with traditional braces and aligners is with InBrace, you have nothing on the labial surface of the teeth. So when I am doing my debond check or I'm letting them know you're about done, I have a lot more patients running their fingers or their tongue along the labial surface of their teeth. And then they'll notice, oh, the transition between one tooth or another is not perfectly smooth. You can't, with braces and aligners, you have something on the front of your teeth. So they don't really notice it as much. But with InBrace, I have had a few patients in recent memory that have said, oh, I'm feeling there's a little bit of a step between my upper 1 and 2 or my lower 1 and 2. In this case, between the lower left 1 and 2, there was a very, very minor step between that there. So, I was telling the patient, it's really very minimal for you to go through a digital enhancement or even to go through some active retainers. It seems a little bit unnecessary. The patient also wanted a fixed retainer to begin with because she didn't really want to wear full-time active retainers. So I just told her, I can just go ahead and polish that for you. And that's what patients, oh yeah, totally just do that. I don't want to go through another digital enhancement where I'd have to wait 4 to 6 weeks for it to fabricate, let it express for 4 to 6 weeks, or I don't want to wear a full-time retainer. I just want to go to a fixed retainer. So I found that this has been very helpful, keeping this in mind for the patients. Last thing is you can use active and or settling retainers to help finish the case. I found that there's many different variations or permutations of how you can do this. So you'll find that with InBrace, because you have brackets now on the lingual surface of the teeth, you sometimes will have to debond the upper arch first to allow for the settling. So you can always I always look at the lingual view when I'm doing my smile design. The other reason is because you're trying to see your SmartWire activations, as Dr. Tera went over. But you often will need to debond the upper arch first when you're having trouble settling. So if you ever see this in your smile design, definitely think, okay, we're probably going to debond the upper arch first. Once I have the upper arch where I like it, the leveling alignment's done, but the patient's potentially biting on the brackets or I have bite turbos on, then I'm going to just debond the upper arch. So if we look at this case here, patient was happy with the upper arch. Only last thing was, for me personally, I was telling her I want a little bit more overbite correction. I don't feel like your bite's settled yet because you're kind of biting on the brackets. So why don't we just start with debonding the upper arch, because that the upper arch I'm going to put in a retainer, and then that allows me to make some adjustments to the lower arch. I can run some elastics. I can still extrude the lower arch if needed. So again, we took off the upper arch. I put a fixed retainer on. I delivered an upper retainer. On that upper retainer, I put some cutouts on the upper ones. So I just used a teardrop plier. But you could just take some scissors and also cut that out as well, just so they can run some elastics. I also put some button cutouts on the upper 6s. This patient was already wearing some class 3 elastics, so she already had buttons on the lower 3s and upper 6s. So all I really had to do was just add, again, some cutouts into the retainer. With the class 3 elastics, she was already wearing medium strength elastics because she was at SmartWire 2. So medium strength class 3 elastics, anterior vertical elastics. Just was wearing it at nighttime. She wore that for about 6 weeks with this settling retainer. And then 6 weeks later, I felt that the bite had settled quite well. Overbite had increased a little bit. So it's subtle, but between the upper debond and lower debond, you can see that everything has socked in a little bit better within that 6 weeks. And then we went ahead and did the lower debond. Another version of this is, so here's another case. Patient, again, was still biting. Biting is minorly on the upper anterior brackets. Overbite and the lower anterior alignment could improve a little bit still. So patient was actually satisfied at this point, but he let me keep going just to do a little bit of final detailing. So we planned on debonding the upper because, again, he was occluding on the brackets. We're going to use a settling retainer on the upper. On the lower, though, instead of we decided to do a digital enhancement. Because there were still some minor rotations in and out differences. Could have also just gone to an active retainer on the lower, totally would have been fine as well. The patient didn't want to have to wear a full-time retainers. They wanted they're good with nighttime, but didn't want full-time retainers. So for the lower, I just went ahead and did a quick digital enhancement. And the digital enhancement, again, less is more. So just add very minor movements. This is exactly the detail bends I would have done if I was doing detail bends on a traditional arch wire. So I just stepped into certain teeth, stepped out lower right 1, added some rotation on the lower right 3. And so in the next appointment, we debonded the upper arch, put the upper fixed retainer in. I did a little bit of enamelplasty and gingivectomies on the upper one. I delivered the lower DE Smart Wire 2 to do that final detailing. Bonded some buttons to start some anterior box elastics. And I delivered that upper retainer that has the cutout. So he's running just box elastics at nighttime. That's going to help extrude the lower anterior teeth to increase the overbite. And then the lower DE Smart Wire 2 is going to be working on the final alignment for this patient. So when this patient came back 6 weeks later, I was happy with the alignment on the lower arch. I was able to debond the lower arch, put a fixed retainer on for this patient. And then between just upper debond and 6 weeks later, again, subtle, but I was happy with that. The bite seemed a little bit more subtle to me in that time frame. So you could also do active retainers. So the last 2 examples just showed settling retainers, taking off the upper arch so that the bite could settle a little bit. So they're no longer biting on the brackets when I'm running the anterior vertical elastics. This patient came in for debond check. Only concern at the debond check, black triangle between upper right 1 and 2. So, I gave her a few different options. I told her, we just need to do some IPR here. We can keep going with InBrace. I can submit for a digital enhancement. It's going to take about 3 months of a turnaround time between 4 to 6 weeks of fabrication. I'm going to then give it to you, let it express for 6 to 8 weeks. That will close the black triangle for you, or at least significantly reduce it. Or we can just do some active retainers. Patient elected for active retainers because she was going to wear full-time retainers anyway. So at the debond visit, I did the IPR between upper right 1 and 2. The same visit, I delivered some active retainers. I gave her 4 active retainers to be worn at 2-week intervals. So she wore that for 8 weeks. 2 months later, she comes back and was very happy with the black triangle close. So again, you don't always have to do it with InBrace. Sometimes it's just easier to do it with active retainers, especially when the patient is eager to get to finish treatment. Another permutation of this is now we're going to go over using settling and active retainers together. So in this case here, patient was fairly happy with treatment. However, upper left 5, 6, the space opened up. So that was the only remaining concern at this point with the upper left 5 and 6. For me, I was telling him, I don't like that your overbite is a little shallow, but I had been actually trying to close his overbite, but he was biting on his upper brackets. So I told him, I'm just going to debond your upper arch. It worked out well because I need to debond your upper arch first anyway, so that I can let you settle better. I can run box elastics. And then while I'm at it, I'll just add some space closing. So I'll make it an active retainer that closes the spaces between the upper left 5 and 6. So on that upper debond appointment, I gave him 2 active retainers that were going to close the upper left 5 and 6, worn at 2-week intervals to close the upper space. At the same time, I put some cutouts in on the upper 2 so you can run some box elastics at nighttime. And then when the patient came back 4 weeks later, after wearing the 2 active retainers for 2 weeks each, the upper left 5, 6 space had closed. And then I was satisfied that the overbite had deepened sufficiently, the bite had settled, where at the upper debond, I could see that after I took the InBrace off, that there was some daylight where he could actually, you could actually see that the lower incisors and upper incisors were not occluding with each other. And then 4 weeks later, you can see that the bite has settled quite nicely with the anterior box elastics. So when you are ready to debond, our recommendation, you just take an angulated bracket remover, grab it from the occlusal and gingival. Usually I roll towards the occlusal because I'm also pushing from the labial with my offhand. So that kind of prevents that torquing force, that prevents the patient feeling that torquing force. So it makes it a little bit more comfortable for them from a removal standpoint. We do recommend using a 2x2 piece of gauze as a throat pack, particularly, especially on the upper. When you are debonding the brackets, sometimes that can actually disengage the bracket from the wire from the bracket. So again, you don't want a patient aspirating any part of the bracket or the wire. So it's just important to use that throat pack. I really personally like using GoTo adhesive. You can use GoTo or Light Bond as part of a required material. GoTo though actually does allow for it fluoresces under a black light, so it makes it a lot easier and faster to remove it all when you have the visualization with the black light. We use either a round diamond or carbide burr for bulk removal. You can use the football burr as well. And then a rounded white stone is usually helpful for anterior polishing and a flame white stone for posterior polishing. One debond management pearl that we kind of abide to, we heard about this from Dr. Jeff Kozlowski on the Elevate Ortho podcast was to try to debond people as like when possible for using a same-day debond. So when the patient comes in for a debond check, if you have time in your schedule, just go ahead and debond them at that appointment, or try to bring them in sooner rather than later, rather than bring them back like in their normal 6 to 8 week appointment interval. Try to bring them back, say, in the next week or two if you have an open slot. Dr. Jeff Kozlowski actually, at least at the time when he gave this podcast, he actually gives a $50 bonus split amongst his team, because he has a full day schedule already planned. When you add something onto the schedule, stresses the team out. But if they have that monetary bonus, then everyone's going to pitch in to work harder and faster to make sure that they still finish on time. But in doing so, you save an appointment, you reduce that risk of a space opening up or a bracket popping up. So this is with traditional braces, aligners, InBrace. It applies to all, any treatment modality. But we have found, this has happened to me for every modality where a space opened up or a bracket popped off and then a rotation happened. So this is something I actually started using in our practices. And we found that it just makes things a lot more predictable, and it reduces, it saves you an appointment here and there. The retention protocol that I use for InBrace cases is we do upper 2 to 2 and lower 3 to 3 fixed retainers, and then a nighttime upper and lower S6 retainer. I've given essentially any option with patients, whether they want fixed or they want removable or they want a combination of both. What most of my patients we found with most of our patients is they do not want to wear full-time retainers. Personally, for me, I like full-time retainers for 6 months, but most of these InBrace patients chose InBrace because they don't want to deal with the hassle of full-time retainer or aligner wear. So I tell them, we'll put you in fixed retainers, just wear something at nighttime. After 6 months, because you did wear something full-time for 6 months, but they were fixed retainers, I give them the option that I can remove it for them. Or if they're good with wearing it longer, because I tell them it doesn't hurt, it actually is better to wear it longer. You have that double coverage. Just keep wearing the fixed retainers. So just troubleshooting the finishing process when the teeth are not detailing as expected. Most of the time, go back to your smile design. A lot of times the smile design may not have been set up properly. You didn't follow that less is more philosophy. You added a lot of excessive movements, particularly torque a lot of times, where that may have resulted in an unfavorable side effect. So now with IFS coming on board, if you decided to opt into your early access, we will be adding IFS movements to counteract any unfavorable side effects. However, it's still a lot more predictable if it's an unnecessary movement to remove it, and rather than us having to counteract a side effect of an unnecessary movement. So that's always going to be less predictable than just not having to deal with the side effects. If sometimes you need additional force for certain movements to express. So again, IFS, if you do opt into early access, will help account for this. We do add on those extra force movements when we see it's necessary. If you do notice that spaces have opened up, there's usually 2 reasons for it. First reason, again, is you have that increase in inner bracket distance that resulted in that open coil spring effect. We do actually know exactly why this happens. With IFS, we do counteract this. So that's something you don't really need to think about if you opt into IFS. If you don't opt into IFS, then it's something that you need to add in yourself, that additional virtual power chain. If you do find that you having some spaces open up in the lower anteriors, generally, a lot of times that's, again, due to the narrow anatomy. So if that happens, just make sure to item request for an IP loop design 3 for narrow anatomy. That right now it's a manual process because this is a new update to the SmartWire, but we are automating this process. So in the near future, this will be automated, but just for the next month or 2, you may have to manually request that. If you find that rotations are not expressing properly, most common reason is that the bracket position is off-centered. So either you need to reposition it, or you may need to just apply some rotation over correction. It just depends on where you are in treatment. But a lot of times in detailing, if it's really far off, you're probably just better off repositioning it. If it's just kind of just slightly off and you just need a little bit more, then maybe you can just consider doing some rotation over correction. Generally with IFS, we are looking at this as well. So most of the time we will, this is caught as well for you. And then finally, it may just be that the clinical force system isn't set up properly, meaning if you need to settle the bite, you need to try to close the anterior open bite. Even if you added over correction for open bite correction in your setup, most of the time you would need to support that with, say, some vertical elastic. So or you may certain movements, sometimes you have to support with an auxiliary appliance, or if you're trying to, again, close an open bite and the patient's biting on the brackets, then you need to use like a settling retainer, or you could use active retainers. So that's a lot more in the under what providers, you as doctors would be taking care of. If you are having trouble with finishing and after you just can't figure out what's going on, we do have a clinical review process available for all providers. You can just sign up through Calendly at this link right here. We do have a clinical advisor available just about every business day, so we're always happy to meet with providers. If you do have a case in progress, meaning you haven't had a recent digital enhancement, or there's something in particular you want us to look at just happened in the last visit, it really helps if you submit a updated intraoral scan tooth print. So on your portal, you can just go to the progress records and you can upload a recent intraoral scan or photos. Intraoral scan, though, is much preferred. We'll just go through 2 really quick studies in the last 5 minutes. These are this case I have presented in the past, but I just wanted to take a different lens at it, kind of looking at mainly from a finishing perspective. So this is a super straightforward case. Chief complaint was just that gap between the front teeth. Treatment estimate was 6 to 12 months. Just skipping forward to his 4th appointment. Face is already closed. Face actually closed in the first month or 2 for this guy. And then at this point, actually, he had no concerns. If I had debonded him at this point, he would have been totally happy. I did tell him I wanted to try to improve the finishing. So he let me kind of go forward with a digital enhancement. But at this point, we've finished stage 1 and stage 2 goals. We finished all the prerequisites. In retrospect, when I look back, and I'm going to go over where I went wrong and why this case took a lot longer to finish, and what provider errors what doctor errors you can make. But in this case, looking back, if I really wanted to finish this case, in 6-7 months, I could have debonded him at this point, put him in some a settling retainer or an active retainer for any minor movements on the lower and the upper. One of the things that you'll see is I was trying to get more overbite correction, but he was biting on his upper bracket. So I had him run a lot of anterior vertical elastics. It wasn't really improving. And you'll see I actually tried placing bite turbos on, still wasn't really improving. And then finally, I just put him in a settling retainer, then it closed the overbite. So there's a lot of ways that I could have finished this case in 6 or 7 months. The other thing is you can, again, the small design is extremely important. So this is one of the cases where we found, okay, we got spaces forming because the small design, if you look at particularly between the upper 5s and 6s, the inner bracket distance is increasing because of that molar rotation on the upper 6s, and that causes space to open. So this is again where sometimes doing too much will add on to your treatment time because you're exposing yourselves to more potential errors. So in this case here, I actually even decided I want to try to rotate the upper 7s and the upper 6s a little bit, even though the bite was pretty good and it was already in a pretty good position. But I decided, okay, I'm going to put upper 7s on. I'm going to place some bite turbos in the upper 7s because a lot of times when you place upper 7s, they're going to be biting on them. So you have to place some bite turbos. Also, because when you place new brackets, sometimes you can't engage the upper smart wire 2 yet. You need to start with the upper smart wire 1. So it's another thing that's going to extend your treatment because I have to now work up to the east smart wire 2 on the upper. I went ahead, go to lower DE smart wire 2 here. A lot of times what may happen is, your posterior bite turbos start wearing off. Patient starts biting on the brackets on those upper 7s. When that does happen, you may forget a debonded upper right 7 or upper left 7. In this case, actually, patient came back twice for care and repair visits because of the upper 7s. I realized, these actually aren't really necessary for treatment, so I just decided to leave them off. But again, this is something that added some appointments to this case when it was unnecessary for me to add the upper 7s. Your patient, the bite was actually good. 6s and 7s were stocked in nicely already. I was just trying to do some final rotations, but again, they were unnecessary in a case like this. I did go ahead in the next visit engage the upper DE smart wire 2. We started again trying to close the open bite or the open bite tendency. So I was running some anterior vertical elastics. This is the case where the incisive papilla was pretty inflamed, so I couldn't get the IP loop around the upper 1, the elastic around the upper 1. So we did from upper 1-2 down to the lower 2s. Also was trying to get a little bit more overjet, so I started running some class 3 elastics as well. In the next visit, when I saw him for a debond check, we realized there's some spaces forming between the upper left 5 and 6 and upper right 5 and 6. Again, this is because of that open coil spring effect because that inner bracket distance increase. So we now know exactly how to counteract that. We're teaching about it. Plus, we will add that into IFS for you, so you don't even need to worry about it if you've opted into IFS. So this is totally preventable at this point. I did try to close the spaces manually, so I was just trying different things. So on the right side, I put like a triangle elastic. That way there's some horizontal force from the labial. On the left side, I actually bonded some buttons to run a power chain. I found that it didn't really close the space like we wanted. So we just went ahead and did a digital enhancement to close the space. Again, for closing the anterior open bite, I actually had to put posterior bite turbos because he was biting on the brackets to try to close that overbite. So just went ahead and submitted for digital enhancement. And in this digital enhancement, we added some additional virtual power chain to make sure those spaces closed between the upper 5s and 6s. And we did that in very, very minor detailing. So when the next visit, we just simply added engaged the upper DE2 small OR2. Lower was good, didn't need to do anything on the lower, but we just did an upper only DE. Patient again is biting on the brackets. I realized it's not working with the posterior bite turbos. So why don't we just go ahead and debond the upper arch in the next visit? So we went ahead and debonded the upper arch, gave him a settling retainer, and he was running some anterior box elastics to help extrude the lowers. And then when the patient came back a month later, or about 6 weeks later, was satisfied with the overbite correction. So again, the settling retainer worked really nicely. So in this case here, really, when you're kind of at that detailing stage, less is more. I added 7s that were unnecessary. I added some rotations that were unnecessary. That caused some space opening. Closing an overbite when you have anterior interferences, really nice and quick to do it with settling retainers. And so last case going to go through quickly is dealing with like a posterior open bite. So this patient actually presented with a posterior open bite, but if you develop the posterior open bite after your initial set of wires, which is fairly, which does happen, usually it's due to a premature anterior interference. So usually it's either you have a Bolton discrepancy with undersized upper-lateral, you need to do some lower IPR, maybe you didn't get enough torque on your upper 2 to 2, so you need to add some torque. So generally it's add torque to your upper 2 to 2 if needed, do some lower IPR if needed, and run some class 3 elastics if needed. Sometimes it's also due to a deep lower curve of SPI, so sometimes you have to add a reverse curve. Those are the main things that you would do to deal with the posterior open bite. As long as you deal with the premature anterior interference, then you'll be able to settle the bite pretty easily. So in this case here, with a small design, because this is how the patient presented, I wasn't exactly sure how her bite was, so I didn't add any vertical overcorrection. I just allowed them to place into ideal. Main thing here is I was going to add some class 3 elastics, particularly on the left side based on where the midline is, and then I added a good amount of lower IPR. Notice that the patient did have a fixed retainer, so you can submit the case with the fixed retainer in. We can digitally remove that for you. And then we just did any detailing movements. So looking at it from just, again, general finishing perspective, look at your treatment instructions, fulfill the prerequisites. This patient started with an off-centered bracket on the lower right 3. So you go ahead and make sure that you're going to reposition that. We're going to do our IPR early here. So we did upper and lower fitting, did some lower IPR. The next visit, we repositioned that lower right 3 bracket, and we started your elastic. So here we did a class 3 elastic on the left side. Actually did a cross elastic version because the transverse was a little bit narrow on the lower arch. On the right side, the upper right 2 and 3 were a little bit higher. So I just did actually a vertical cross elastic between the upper right 2, 3 IP loop down to the lower right 3. And then very importantly, I also finished all the prescribed lower IPR. So when the patient came back in the next visit 2 months later after wearing elastics and after all that IPR spaces had closed, we were able to get rid of the premature anterior interference. So then at this point now the bite's essentially settled. Makes the case a lot easier at this point. So at this point, we're just running our elastics, trying to get the bite, trying to finish your stage 2 goals. The main stage 2 goal is, again, resolve all your inter-arch discrepancies. Patient then comes in for digital enhancement. We mainly use some minor detailing. And then digital enhancement start, look at your DE instructions. In this case, we don't need to do any repositions, no more IPR is prescribed. So we engage engaged your upper and lower DE small OR2. We adjust the rubber band pattern. That means that's kind of gone through all the general goals of your systematic approach to finishing. Patient comes in for a debond check. She came from very far away to see us. So kind of, again, like what Dr. Jeff Kozlowski says, if you can do a same day debond, do the same day debond. So we went ahead and debonded her at this day and did a little bit of enameloplasty. So Again, just a review of our systematic approach for improving finishes with InBrace. Perform your prerequisites for predictable finishing, the same as any other orthodontic treatment modality. Submit proper DE records. Proactively adjust your DE smile design. Perform your clinical adjustments to support your finishing, so follow your DE instructions. Do any enamel and plastic equilibration and composite restorations as needed. Allow the SmartWare to express, SmartWare D, SmartWare 2 to express. Resolve any remaining interarch discrepancies, so run any settling elastics that you would, same thing as you would do with traditional braces or aligners. And then if needed, use any active or inner settling retainers, particularly settling retainers when the patient's biting on the bracket and you aren't able to settle the bite. So that completes this webinar. Can we finish? Yes, we can. And then look out for our webinar next month. And next month, we're going to be going over cases with vertical discrepancies. And then now we can go over any questions.
Dr. Lee, thank you for that. So we do have some questions. One was, where do you get your clear buttons for elastics? The buttons you are using look like rectangular on the lower twos versus round clear buttons. So, maybe let's go over all the different permutations of how you create the buttons.
So with clear buttons, we've tried a lot. I would say that I wouldn't say that we love any of the clear buttons we've tried. We've tried buttons from OrthoZone. We've tried buttons from Allure, and then from American Orthodontics. Also, we tried splitting the 3M lower anterior bracket in half, which is very expensive. After trying all the different ones, we've also tried mini molds as well. We've generally gone back to like the rectangular ones that we get from American Orthodontics. I think American Orthodontics actually supplies that from a different vendor. So many companies use it, but we found after using 4 or 5 different types, the clear rectangular ones seem to work the best. We can also debond them a little bit easier compared to like some of the round ones. They actually will break off just the head of the button. So that's been kind of annoying for those ones. So yeah, we generally just use the rectangular ones. When I do have a patient that comes from far away, or maybe has debonded a rectangular button, sometimes I'll go to the mini mold. I found mini molds I have a little bit less bond failure with. So that's the other option that I use once in a while.
Okay, that's great. And then let's see here. What retainer material are you using for settling active and fixed retainers?
So normally we use the Zendura material. So it's very common. I would say one of the most popular ones for active retainers. So when I'm running for settling retainers or active retainers, I mainly will use the Zendura 030 material. And then when I do a final passive retainer, I'll just use a standard 040 Essex retainer. We just get that from Great Lakes. For fixed retainers, normally we'll just use the OrthoFlex from Reliance. And then if there is a diastema, we'll generally use Retanium instead of OrthoFlex just in that scenario.
Okay, and the last one is, are you using SmartWire 3 at all for finishing?
Generally, we don't. So most of the time you can start and finish with SmartWire 2 when you're doing your detailing. So using SmartWire 3, I would say, is just an extra step that doesn't really add anything. The SmartWire 2 should be able to express just about everything. Usually SmartWire 3 is used for very specific movement. So say when you're doing your major mechanics back in stage 2, you're trying to say level a deeper curve of speed, you're trying to get a little bit more transverse expansion, you're trying to get a little bit more torque on your upper incisors, you have a large tipping movement, you're trying to get a little bit more tip from. That's when you would use SmartWire 3. But when it comes to finishing, generally you don't need to use SmartWire 3. Usually I would say it's extra work that you can avoid doing.
Great. Well, I think we're a little bit over time, but a lot of folks staying engaged and still staying here to the end. So thank you everyone for joining in this webinar on Can We Finish? Yes, we can. As Dr. Lee mentioned, we're going to have these every month, touching upon different topics. And the best thing you can do for us is to take the survey that we're going to send out at the end of this webinar, which is going to give us feedback on how we can continue giving you content that you find useful. And also, if you find this useful, please tell a friend, because the best way of spreading the good news is sharing all the good news that we have. So with that being said, thank you for joining in, and we'll see you at the next session of WTF.